This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
I've shared your contact details in the live in case people want to contact Dr. Kong or yourself. Another question from Jen. How do you help a couple choose between trying naturally a bit longer, IUI, and IVF without wasting time?
It's all about age. And it's all about, I'm afraid, all about a specialist approach. I'm conservative. I actually think that there's far too much IVF done that is probably unnecessary. And it should be the end of the road. And that's the way I generally sell it to people. So natural conception. Okay. The data is, is 50 years old or longer. Natural conception in women under 35, provided they have normal sperm, normal fallopian tubes open, and a regular ovulation, in 12 months, 90% will be pregnant without me lifting a finger. The problem I have today is that at 6 months, women are coming because they want a baby 6 months ago, because that's when they started trying, and say, I want something to happen. So as much as I might preach, hang in there, because in the next 6 months, you've actually got more chance of getting pregnant on your own than with a one cycle of IVF. That's where but that's under 35s, much more, be more patient. Maybe I'll give you a touch of ovulation stimulation with letrozole or clomiphene, but encouragement to do so. Once you get to 35, I start to think, well, maybe after 6 months, we should be moving on, certainly investigation-wise, to make sure that everything is normal. And during those investigations, I've probably bought myself another month or two, and spontaneous pregnancies occur, particularly doing the tests we use to make sure the tubes are open, where we flush dye up through the cervix, through the fallopian tubes. And in the 2 or 3 months after having that test, there is an increased pregnancy rate. So that's one of the things I do to try and keep people trying on their own for that 2 or 3 month period. If that fails, then we're going to talk about IUI. IUI, its positives are that it's much less invasive than IVF, but along with it is the pregnancy rate is significantly less than one cycle of IVF. So one cycle of IUI in a woman under 38 is somewhere between 15 and 20% chance of a pregnancy. In women under 38 having their first cycle of IVF, it's more like 35 to 40% with the first embryo transfer. But IVF is more invasive and more intense in terms of visits to clinic and procedure in the operating theatre, as opposed to just having insemination done. And then obviously the other issue is the financial side of things. So these days, in terms of life fertility, for an IUI cycle, the patient's going to be out of pocket around $1,800. With an IVF cycle, they're going to be out of pocket after Medicare rebates of $6,500, $7,000. So there is a difference in terms of price. So all of those things come into the equation. Once we get to 40 plus, really people shouldn't wait. And so IUI is one option, although by then the results for IUI over 40 are pretty dismal. If you've been trying for a while before, if you've been trying for 12 months and then you do IUI, your odds of pregnancy at 40 per month, probably less than 5%, even with IUI. Whereas with IVF, at a 40-year-old, we expect a 25 to 30% chance with one embryo transfer. And they may get more than one embryo transfer in subsequent cycles. So moving on to IVF in that older age group is much more common.
One last question, Prof. How do you approach IVF for patients who have had previous pelvic surgery, and how does surgical history change your risk assessment before retrieval?
Okay. Well, it depends a bit what the pelvic surgery was for. Was it done? So people have pelvic surgery because they might have had an ectopic pregnancy. Let's start there. So that shouldn't really change anything from IVF side, except if the underlying reason for the ectopic was significant pelvic infection. In that scenario, we're obviously going to be thinking about giving prophylactic antibiotics. The next pelvic surgery we can talk about is endometriosis surgery. With endometriosis, you can get lots of scarring, and the ovaries may be more difficult to access. So we always insist on an ultrasound before we start a treatment cycle in a patient, particularly in a patient who's previously had endometriosis and had surgery for it. Other pelvic surgery, removal of fibroids. Again, adhesions are an issue, and recurrence of the fibroids, making it difficult to get at the ovaries. And again, an ultrasound before a cycle should be done to assess the accessibility of the ovaries. Doesn't mean we can't go ahead, because we can collect eggs transabdominally as well as transvaginally if the ovary is sitting up to your line. So pelvic surgery, previous pelvic surgery is not that uncommon, because that's what's made, or whatever, or treating what the problem they had, or the surgery itself might have produced adhesions and scarring, and that IVF really might be the only way forward to actually get the eggs and the sperm together. So it doesn't put us off. We just have to be aware of those risks. With endometriosis, the additional important thing is that introducing infection is a real risk with endometriosis, and we always give prophylactic antibiotics if we're doing an egg collection on a woman with particularly an endometrioma.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.